pleasure to welcome each one of you over here to the second day of Physiology Foundation Day Celebration 2023. The center of attraction of today's program is a major event that is working model competition by the first year MBBS students. So creativity is seeing what others could see and thinking what no one else would have ever thought. So today, let's have a look into the creative and innovative ideas of the first year MBBS students. Before moving on to the competition, let me welcome the respective panel of judges who will judge today's working model competition. So I would like to call Dr. Rekha Chivani, Additional Professor, Department of Physiology, to give away a floral welcome to Dr. Roshan Chanchalani, Additional Professor, Pharmacology. Pediatric Surgery, Associate Professor, Pediatric Surgery. Ma'am, please. Now let me invite Dr. Varun Malhotra, Additional Professor, Department of Physiology, to welcome Dr. Ashok Kumar, Additional Professor, Department of Biochemistry, with the flowers. So I would like to invite Dr. Rachna Parashar for welcoming Dr. Shilpa Khore, Additional Professor Pharmacology, with a floral welcome. Now let me invite Dr. Ruchi Singh, Additional Professor Physiology, to read out the rules and guidelines for today's competition.
So all the best to all the teams, and we do not know which number the respective teams are coming because they have been allotted names of the scientists and they are being called randomly, right? So each group shall be allotted 10 minutes, 7 minutes for presentation and remaining time for interaction with judges or the audience. Each team will receive a name by lottery system and project presentation. The order will be decided accordingly. The name of the mentor is not to be mentioned during any time of presentation. Please do not acknowledge. We all are your teachers, but you can acknowledge it afterwards, but not in your presentation. And the decision of the judges will be final. And 3 best models will be selected for first, second, and third position. So wish you all the best.
So now it's time for me to call the first team. That is the team Dr. Odar Singh Penal, and they will be presenting the model on the gauge control theory of pain. So the team members can kindly come to the stage to present your model. Today, huge round of applause for the first team, Team Odar Singh Penal. Okay. You have a total of like 7 minutes to talk, and at 5 minutes you will be given a warning bell, and at the end of 7 minutes there will be the final bell.
India का झंडा डिपार्टमेंट ऑफ प्रोजेक्टर ऑफ कर राइट ऑन
Are you ready? Okay, your time starts now.
Okay, so good afternoon, respected judges, respected professors, and my dear friends. So our presentation is on the gate control theory of pain. So I'll like to start with a very familiar example, which we have all basically experienced in our lives. So whenever while playing, when we were little children, so whenever while playing, we hit our head hard, either with some wall or maybe with some stone or anything. So the first reaction that we or our mothers would have is like rub our head. So what is basically the concept behind this? Why that rubbing reduces the sensation of pain in our body? So we'll be explaining the physiology behind this, and this is basically explained by the gate control theory of pain. So we basically have two types of receptors in our body. So the first one is the pain receptor or the nociceptors. So what basically happens is that when we hit our wall, there takes place the damage of tissues. So these damaged tissues release proteolytic enzymes. So these proteolytic enzymes in turn cause the secretion of various substances from the mast cells such as histamine, bradykinins, serotonin, and these substances in turn are involved in the regulation of pain. So there are two types of nerve fibers which carry these pain sensations from the nociceptors up to the level of the spinal cord. So these are the A delta fibers and the C fibers. So as we have presented here, these are the A delta fibers and C fibers. So A delta fibers are basically the fibers for fast pain. They contain more myelination, and the speed of conduction is about 12 to 30 meters per second. And the C fibers are comparatively less myelinated, and the speed is very less, about 0.5 to 2 meters per second. And these fibers enter through the dorsal nerve root and the dorsal gray horn of the spinal cord, and there they synapse with the interneuron in the substantia gelatinosa of the spinal cord. After that, these interneurons in turn synapse with the second order neuron. The second order neuron crosses the gray matter to enter into the white matter, and through the anterior spinothalamic tract, they ascend upwards up to the level of the spinal cord, from the up to the level of the thalamus in the brain. So from the level of the thalamus in the brain up to the sensory cortex, there is the role of the third order neuron, which carries involves the carrying of the sensation of pain from the nociceptors up to the level of the sensory cortex. Now I'll be explaining so up to here it was the part where we get hurt. Now on I'll be explaining the part when we start rubbing. So in this, basically there is the role of mechanoreceptors. So from the mechanoreceptors, the A beta fibers carry the sensations up to the spinal cord through the same pathway as it is sensory, we all know, through the dorsal nerve root, dorsal gray horn, and from here on they cross into the white matter through the dorsal medial lemniscal system, and they ascend upwards and up to the level of the thalamus, and then through the somatosensory sensory cortex in the brain. So these A beta fibers, they give collaterals. So these collaterals are known to synapse at the interneuron which was present in the substantia gelatinosa. So this interneuron is basically a inhibitory interneuron. So this inhibitory interneuron is known to act at the presynaptic terminal at the synapse between the first order neuron, that is the A delta and C fibers, and the these collateral acts at the synapse of the A delta and C fibers with the interneuron dominant in the substantia gelatinosa at the presynaptic terminal. So when this is activated, the A delta and C fibers, they are inactivated, and thus the sensation of pain is reduced in our body. Now, Priya.
So we've seen the conventional gate theory. Now there's another integration that is taking place at the dorsal horn. So we've seen the original pain pathways that are going up to the brain. Now as they're ascending up, they send certain collaterals to other parts of our CNS. Particularly the PAG, that is the para-aqueductal gray in the midbrain, and the nucleus staphylococcus magnus in the nucleus reticularis gigantocellular. So what happens is when they send collaterals, they are stimulating or activating a descending pain modulation pathway. This pain modulation pathway, basically, the PAG will send encapsulinergic interneurons to the nucleus staphylococcus magnus. The nucleus staphylococcus magnus will send serotoninergic neurons to the interneuron that is present in the substantia gelatinosa. Now that the interneuron, it is inhibitory. It is producing certain chemicals that we know as opioids. These opioids are the main players here because they will bind to the presynaptic terminal, the receptors that are present there, and the postsynaptic also, and they will cause the same thing that we have seen in the gate control theory. They will cause the inhibition of it. So that is how there's integration of the conventional gate theory that we just explained and the descending pain modulation. This has widespread applications all throughout because the acupuncture that is used for therapy, the physiotherapist, the TENS, that is the subcutaneous electric nerve stimulation. These are certain applications because the physiotherapist can stimulate, they can find ways to activate and stimulate this descending pathway, which will be acting through this gate control theory only, and thus the pain can be modulated in the patients, in post-operative patients or patients who are suffering from certain debilitating diseases, chronic pain. So that is how the gate control theory is coming in. Thank you. Thank you, team. Over to the judges.
For any
Any questions from the audience? So over to the group.
What happens in diabetic neuropathy? To pain. What is the influence of diabetes to pain?
Thank you, judges. Thank you, team.
This was the first one.
Next, I would like to call upon the second team, that is the team Dr. Baldev Singh, who will be presenting with the menstrual cycle model. So kindly come up to this. Please put a huge round of applause for the second team. Dr. pain. Team members, are you ready? Okay, your time starts now.
Good afternoon to everyone present here. Today the topic for our project is menstrual cycle. So as we know, menstrual cycle is a sequence of events that takes place in females every month in preparation for the possibility of pregnancy. I'll be first explaining the ovarian cycle, the changes that takes place in the ovary. So from the hypothalamus, first we have the hypothalamus releasing gonadotropin releasing hormone, which acts on the anterior pituitary to release luteinizing hormone and follicular stimulating hormone. In the ovary, we have around 60,000 primordial follicles present in a female. At puberty, these primordial follicles start maturing under the influence of follicular stimulating hormone. Each month, a follicle is isolated and FSH starts acting on it. The primary oocyte that is present starts gathering a covering of granulosa cells around it. These granulosa cells surround it and form the primary follicle. The primary follicle gathers more and more granulosa cells around it to form the secondary follicle. The secondary follicle is characterized by a distinct theca externa and a theca interna. The theca interna is responsible for secreting estrogen. Then the primary oocyte within the secondary follicle undergoes meiosis 1 and becomes the secondary oocyte within the tertiary follicle. Then we have the development of the Graafian follicle. Over this entire course, the level of LH and FSH is continuously increasing. Then on day 14 of the menstrual cycle, we have LH surge, which is a sudden increase in the level of luteinizing hormone. Because of that, it induces the Graafian follicle to rupture and release the secondary oocyte, along with a layer of granulosa cells around it, which is known as the corona radiata. This event is known as ovulation. After this, we have the remainders of the Graafian follicle become the corpus luteum. The corpus luteum secretes progesterone. Eventually, the corpus luteum will, if pregnancy does not take place, the corpus luteum recedes to form the corpus albicans. Now I'll hand over the mic to Vijot.
Hello everyone. Coming to uterine changes. The uterine changes begins with proliferative phase, where the thickness of the endometrium increases gradually over the course of 14 days uh, due to increase in cell size and cell number of the endometrial cells. This is stimulated by the hormone estrogen, which is secreted by the developing follicle in the ovary. Also, the tubular glands start developing in the course of 14 days and increase in the length of the gland. And also the spiral arteries start developing. On the day 14, 14 days prior to menstruation, ovulation occurs. In this period, the thickness of the endometrium is maximum and it is ready for implantation. Coming to the secretory phase, when the degenerated Graafian follicle turns into corpus luteum, and corpus luteum releases progesterone, which stimulates the secretions in the tubular glands, where tubular glands secrete carbohydrate-rich mucus and fluids. Also, the spiral arteries become more tortuous and the vascularity of the endometrium increases. As the corpus luteum regresses, levels of progesterone fall, and this causes degeneration of the endometrial layer and causes menstruation. अभी हम demonstrate करेंगे हमारा प्रोजेक्ट. पहले endometrial lining बहुत पतला होता है proliferative phase, starting of the proliferative phase में. फिर धीरे धीरे as days pass by वो बढ़ता जाता है thickness. उनके साथ साथ ग्लैंड्स भी डेवलप होते हैं, स्पाइरल आर्टरीज भी डेवलप होता है. यहाँ पे हमने ग्रीन कलर से ग्लैंड्स दिखाया है और रेड कलर से स्पाइरल आर्टरीज दिखाया है. और ओव्यूलेशन के टाइम ये एंडोमेट्रियल थिकनेस मैक्सिमम हो जाता है. डे 28 या एंड ऑफ मेंस्ट्रुअल साइकिल में जब प्रोजेस्टेरॉन लेवल्स घट जाते हैं, तब ये सारा टिश्यू का नेक्रोसिस होकर डीजनरेशन हो जाता है और टिश्यू बाहर थ्रू द सर्विक्स एंड वजाइना बाहर आ जाता है. This is known as menstruation. Coming to the mechanism of menstruation, when the levels of steroid hormones such as estrogen and progesterone decrease, there is lysosomal membrane lysis, which causes release of proteolytic hormones and also production of prostaglandins. This causes endometrial cells necrosis and degeneration, which is comes out as menstrual flow along with mucus, blood, and prostaglandins.
Okay, thank you, team. Over to the judges. Over to the audience. Audience, any queries?
Any questions from the audience? Team, question.
Have the group got any questions for the audience? You have any questions? You work so hard with the audience.
Okay, so what is the effect of PCOS on menstrual cycle?
So PCOS or polycystic ovarian syndrome occurs due to an unusually high level of androgens present in the female body. Due to the presence of these androgens, small fluid-filled cysts develop along the outer lining of the ovary, because of the level of androgens is so high in the body, it interferes with the menstrual cycle and it will eventually lead to irregular periods, and when they occur for extended periods of time with heavy menstrual bleeding.
Can you just enumerate some menstrual abnormalities in a female? This is normal menstruation. Can you enumerate some of the conditions leading to menstrual abnormalities?
So, coming to the conditions related to menstruation, first we have amenorrhea, which indicates a complete absence of menstruation. We also have oligomenorrhea, which indicates decreased frequency of cycles of menstruation. We also have polymenorrhea, which indicates an increase in frequency of cycles of menstruation. Then we have dysmenorrhea, which many females commonly experience, that leads to painful menstruation. We also have menorrhagia, which is characterized by an increased amount of blood and menstrual discharge during menstruation.
So, thank you, team. So that was
Yeah, it was a well presented project. Just one simple question to all of you. Whoever is okay can answer. You told us about the estrogen progesterone role in regulation and maintenance of pregnancy. Can you just tell me how these hormones given as a part of contraceptive pill acts for contraception?
Progesterone pills are given. It increases the thickness of cervical mucus, because of which the sperm entry can be blocked.
The further development of follicles is does not happen.
So that was team Dr. Baldev Singh. Thank you, team. Okay, next I would like to invite the third team, team Dr. Balkrishnan Anand. They will be presenting on their model on ECG. So team, please come up to the stage along with their model.
So, as you all know, we've chosen the names of these important renowned scientists, especially in the physiology department. The students who've been coming in down the wings in the physiology department must have seen the mentions of these important person, and the importance of which, why we've chosen is because each one had a part to play in the historical field in medicine and how that has played a role in the medicine which we will be learning for the future. So over here, as we have Dr. Balkrishnan Anand, the group over here, we have the group here being represented by Dr. Balkrishnan Anand. And does anyone in the audience, by the faculty and the judges, do they remember what was his most important contribution? Yes.
he was the hypothalamus in brain graph.
Yes, that's correct. He is basically the modern neurophysiologist of India. So that's correct. Thank you, Dr. Bansal. So over to the group. You can commence your presentation.
Honorable Chief Guest and all the respected faculty members present here, good afternoon to one and all. Our project topic is ECG. We actually chosen this topic because it is of lot of interest, means it has lot of application in medical field. So first reason was that through the ECG we can diagnose several diseases of the heart, and we can also monitor them. Like we can see if there is abnormality in the ECG, there is some normal pattern of ECG. If there is abnormality seen in that pattern, then that actually is the indication of a disease. And after that, we give the treatment to the patient, and after that we monitor that how the ECG changes is occurring. That means how that abnormal graph is coming to the normal. First is that application, and second important thing about ECG is that it is a non-invasive process. Means if you want to see the activity of the heart, that is the electrical activity of the heart, we don't need to do some invasive procedure like the surgery. We don't need to cut something or go inside. And also we don't have to use any harmful radiation like UV rays, X-rays. We just need to insert those leads on the body of the person, and from that we get the electrical activity of the heart. And third important thing about ECG is that it is also cost effective. Means the cost for the ECG is not much. It is like very little cost is required for doing the ECG of a person. Then if I talk about the leads, then we have three, here we have shown the unipolar leads. We have the three unipolar limb leads. The first is attached to the right arm, then the left arm and the left foot. And we have six also unipolar leads, which are chest leads, and those are named from V1 to V6. So first, V1 is attached in the fourth intercostal space, just right to the sternum. V2 in the fourth intercostal space, just left to sternum. Then V4 in the fifth intercostal space, along the mid-clavicular line. Then V3 is between the V2 and V4, and V5 is in the fifth intercostal space only, along the anterior axillary line, and the V6 is in fifth intercostal space along the mid-axillary line. So this is the arrangement. Then we also have the three bipolar leads, that is the lead 1, lead 2, lead 3, which we attach in the right shoulder, left shoulder, and left thigh. That results in formation of triangle, that is the Enthoven triangle. So the name Enthoven actually given from the scientist who had discovered ECG, that is the Enthoven scientist. So he is also known as the founder and the father of the ECG. Then if I talk, then what is it? In normal scenario, what we will find certain waves and intervals and segments in ECG, like the P wave, QRS wave, S wave. Means there is certain pattern of them, and there is also certain values of their timing for what duration they occur, what's the amplitude of them. If there is a deviation from that pattern, then that indicates a disease condition. So here we have shown some normal values and also little bit deviation which we can permit. But if the deviation is more than that, and if we see that in the graph, that shows that person is suffering from disease. So such deviation we actually see in certain diseases, like we see in the arrhythmias, that is irregular rhythm of the heart. So irregular rhythm of the heart actually occurs in ventricle fibrillation, then atrial fibrillation, and also in the atrial flutter. And in tachycardia and bradycardia also, we see the irregular rhythm in the heart. Means there is not a proper rhythm, some deviation is seen. That's one thing. That's one diagnosis we can do through the ECG. Then through ECG we can also diagnose like whether the heart muscle is properly working or not. Means what happens if the heart muscle gets damaged in diseases like the heart attack or the ischemia. Then there is also some waves which we see in that heart attack cases. Like here we have a myocardial infection. So there are some specific waves which we are going to see in case of myocardial infection. Then it is also then a doctor actually sees the doctor for means ECG is very useful to doctor. First of all, to diagnose the disease. Then doctor also gives certain treatment to the patient, like the medication, certain cardiac procedure. Then after that, doctor monitors that what changes are occurring, that how I need to improve my treatment to the patient so that that patient can become normal. Now, this machine which we have shown, so on this machine we have certain buttons like the start button, velocity, stop, print, reset. So and there is one monitor. So on that monitor we not only get the ECG graph, we also get certain more parameters about the heart. Like we get that what's the heart rate of the person. Like we come to know that what's the heart rate of the person, then we also come to know that what's the respiratory rate of person, and it also gives us the idea about the blood pressure. That's what's the blood pressure of the person. Then after that, through this wire, Means if from here the leads actually comes out and we attach those leads to the body of the person. Now after that, after recording something, some the ECG graphs comes like this. Means in this way through the machine we get those ECG graphs. So now I would like to hand over to Hardik to explain further.
Hello, good afternoon everyone. I would like to explain with some abnormalities in ECG writing pathology. So first abnormality would be myocarditis. In it, there is inflammation of pericardium and myocardium. So the ECG shows that there is an ST segment elevation and PR segment depression. So next would be the ventricular fibrillation. In ventricular fibrillation, there is it is very deadly arrhythmia and there is irregular ventricular rhythm. So we could see there is no distinct QRS complex but different waveforms for the ventricular activity. And next would be the atrial flutter. Atrial flutter is rapid but normal electrical activity of heart. In it, there is very significant flutter waves, also called sawtooth P waves, which signifies that there is atrial flutter. Next would be atrial fibrillation. In atrial fibrillation, there is rapid and irregular atrial activity that is originating in the atria. In it, there is absence of P waves. Instead, there is oscillating waveforms in place of P waves, and there is irregular RR intervals. The RR interval is variable. And now, I would also like to explain atrial septal stenosis. It is because of complete myocardial infarction of anterior and septal wall of left ventricle. So there is PR segment, ST segment elevation and deeper Q waves in V1 to V4. And so after the acute phase of myocardial infarction, we could also see inverted T wave. Right? And next would be the atrial tachycardia. It is rapid atrial activity. So there is rapid atrial contraction. The heart rate would be around of atria would be around 100 to 250 depending upon the conductivity. And the ventricular activity is normal and it might be irregular if there is any AV block or conduction abnormality. So I would like to hand over to Ishita now.
I will be talking about AV block. So what happens is when there is a defect or delay in the conduction activity from atria to the ventricles, we get AV block. We have first degree AV block, second and third degree AV block. What happens in first degree AV block? There is a prolongation of the PR interval. So this is due to.
Well, that means time's up. We now move on. Round of applause for them.
Thank you everyone for listening us patiently.
Over to the audience. Any questions directed to the group? Yes, we have Dr. Sandeep, sir.
Why atrial fibrillation is not dangerous but ventricular fibrillation is dangerous?
Sir, in atrial fibrillation, there is normal QRS activity, but in ventricular fibrillation, there is not normal atrial activity. And so the main pumping part that is pumping to the periphery of the body is affected. But in atrial fibrillation, we could see that there are normal QRS complexes. That's why. Sorry?
How much blood will move to atrial fibrillation and how much blood will move to the ventricular fibrillation?
So in atrial fibrillation, there is normal conduction because during atrial fibrillation, the impulses are not conducted because the AV node is still in the refractory period. So it will not affect the conduction. But in ventricular fibrillation, what happens is there is decrease in the cardiac output. So it will result in decreased pumping activity of the heart and decreased cardiac output, which will affect.
Cardiac output will be decreased by how much percent?
Sir, in atrial fibrillation it decreases by less than 10%, but in ventricular fibrillation it more than 50% it decreases. Sir.
Yes, ma'am.
Who said that? Yes. Is it self-limiting? Which one is self-limiting out of these two?
How do you diagnose angina on ECG?
Sir, angina actually occurs before the myocardial infarction. So means whatever symptoms we are seeing in myocardial infarction, like the ST segment elevation, deep Q waves, then also the inverted T waves, means little bit of them we will see, like we will see the less deeper Q waves. ST elevation. Sir, the characteristic feature of the MI is the
Can you distinguish recent MI and the past MI? Old MI.
Sir's question, can you distinguish between an old MI and a recent MI? Yes.
Sir, are those which actually generate impulse by their own, like in our body it is SN node. Then if that SN node is damaged, then the AV node starts to generate. Actually inside artificial pacemaker. Artificial pacemaker, sir, name is not known.
Thank you. Thank you. Applause for the team. Thank you. So our next group is a very renowned physiologist whose birthday actually we share the same birthday actually with the Foundation Day of Physiology, as our HOD sir mentioned yesterday, that 12th July is shared with the birthday of Dr. Claude Bernard. So the next group is Dr. Claude Bernard, who will be presenting the topic of mechanism of insulin release. Round of applause for the team. Is the team ready? So the captain of the team will be commencing the presentation. You can begin.
Good afternoon, everyone, respected teachers, professors, judges, and my dear friends. This is group Dr. Claude Bernard's, and our topic is mechanism of release of insulin. Insulin is one of the most important hormone in the body, and it performs various functions in balancing the body energy by regulating the amount of micronutrients in fed state. I will be sharing some interesting statistics about insulin in India. In India, 11.4% of the population suffers from diabetes mellitus, and out of which 4% of the population falls in the age of 18 to 24 years of age, and in 56 to 63 years of age, it is 17%. The beta cells release insulin, and the further mechanism in our project would be explained by my batchmates.
गुड आफ्टरनून एवरीवन. तो बेसिकली इस मॉडल में हमने दो कंपार्टमेंट्स बनाए जो कि बीटा सेल ऑफ पैनक्रियास को रिप्रेजेंट करते हैं. पहले हम बताएंगे अगर ग्लूकोज कॉन्सेंट्रेशन इंक्रीज करता है तो क्या होता है, और दूसरे में बताएंगे कि अगर डिक्रीज करता है तो क्या होता है. तो पहले अगर हम इंक्रीज की बात करें तो जैसे कि हमें पता है कि जो ग्लूकोज है वो बीटा सेल के अंदर एंटर करता है विद द हेल्प ऑफ GLUT2 ट्रांसपोर्टर. तो अगर ग्लूकोज कॉन्सेंट्रेशन इंक्रीज करता है तो ज्यादा से ज्यादा ग्लूकोज जो है सेल के अंदर एंटर करेंगे, फिर वो ग्लूकोज जाके ग्लाइकोलाइसिस और सिट्रिक एसिड साइकिल को परफॉर्म करेंगे, जिसके कारण से ज्यादा एटीपी प्रोड्यूस हो. अब ये एटीपी जाके एटीपी सेंसिटिव पोटेशियम चैनल पर जाके क्लोज कर देगा, जिसके कारण से जो नॉर्मली पोटेशियम आयंस इफ्लक्स होता है वो इफ्लक्स बंद हो जाएगा, और उसके कारण से सेल के अंदर पोटेशियम आयंस एक्यूमुलेट होंगे और सेल की पॉजिटिविटी को बढ़ा देंगे, जिसके कारण से जो सेल मेम्ब्रेन है वो डिपोलराइज हो जाएगा. तो अब इस डिपोलराइजेशन के कारण से जो वोल्टेज गेटेड कैल्शियम चैनल है वो ओपन हो जाएगा. और क्योंकि ईसीएफ में कैल्शियम कॉन्सेंट्रेशन इज मच मोर देन आईसीएफ, तो कैल्शियम जो है इन्फ्लक्स होगा सेल के अंदर. अब ये कैल्शियम आयन जाके प्रोटीन काइनेस सी को एक्टिवेट करेगा विद हेल्प ऑफ फॉस्फोलाइपेज सी. अब प्रोटीन काइनेस सी दो चीज करता है, एक तो जो कॉर्टिकल एक्टिन नेटवर्क है उसको स्टिमुलेट करता है, और दूसरा जो स्नैप 25 प्रोटीन है और जो साइनोटैग्मिन है जो कि बेसिकली एक्सोसाइटोटिक प्रोटीन है उसको भी एक्टिवेट करता है, जिसके कारण से जो बेसिकल्स है जिसके अंदर बेसिकली इंसुलिन है वो माइग्रेट करते हैं टुवर्ड्स द सेल मेम्ब्रेन. फिर जैसे माइग्रेशन जब सेल मेम्ब्रेन के पास पहुंच जाते हैं, इनका मेम्ब्रेन और सेल मेम्ब्रेन फ्यूज कर जाता है, एंड थ्रू एक्सोसाइटोसिस ये अपना कंटेंट यानी कि इंसुलिन को ईसीएफ में रिलीज करते हैं. अब ये इंसुलिन जाके मेनली 3 एरियाज में एक्ट करते हैं, लीवर, एडिपोज मसल, स्केलेटल मसल, और ग्लूकोज कंसंट्रेशन जो इंक्रीज है उसको डिक्रीज करते हैं. तो अभी हम बताएंगे अगर डिक्रीज करे तो क्या.
Good afternoon, everyone. Now we are going to talk about whenever the beta cell is at rest. So, whenever the beta cell is at rest, that means the insulin is not supposed to be secreted. This happens whenever the glucose in blood is already low. So, whatever the low glucose in blood is present, it passes through the GLUT2 transporter into the beta cell. So, as there is a less amount of substrate, the metabolism via the glycolysis and the citric acid cycle also decreases. So because there is less metabolism, there is less ATP, and the potassium ATP channel do not close. They remain open. So substantial amount of potassium leaks out of the cell, and which brings cell from the depolarized state through the repolarization back to the resting membrane potential. Since the cell is at resting membrane potential, the voltage gated calcium channels do not open because it requires a depolarized state. So since the calcium does not open, as mentioned by Parthiv, calcium does not induce the activation of protein kinase A, and there's no activation of protein kinase A, then actin and SNAP25 proteins are not activated, thereby the vesicles which are here remain in the cell, do not go to the membrane, hence insulin does not.
So we have seen how important insulin is for glucose transport into the cell. So what if this insulin doesn't function properly? Or else what if this insulin is not secreted in enough amount? We have two major diseases known as diabetes mellitus, type 1 and type 2. The main important disease nowadays which is growing in India is diabetes. What is the main reason behind diabetes? It may be lifestyle changes or the kind of food habits that we are taking. So how is type 1 different from type 2? In the case of type 1 diabetes, it's an autoimmune disorder. In that disease, the beta cells of pancreas undergo lysis, which means that there is a less amount of insulin being secreted. Whereas in type 2 diabetes, the insulin is being secreted in normal amount, but the problem lies within the receptors. The receptors become more resistant to insulin. That is, they require higher concentration of insulin for it to get activated. So, if we see in the case of type 1 diabetes, it's because of low insulin secretion. So, even if there is large amount of glucose, the amount of insulin is very low. The glucose cannot enter into the cell. So, we'll have normal level of insulin in the body. Whereas in the case of type 2 diabetes, we have improper functioning of the receptors, or the receptors are highly resistant. So, how can the body correct it? The body will think that there is less insulin secreted, so the receptors are not able to detect it. So what the body does, the body will secrete more amount of insulin in the assumption key because there is low insulin, the body is not able to get enough glucose. Okay, now the disease diabetes mellitus is characterized by polyuria, polydipsia, and polyphagia. Diabetes mellitus leads to complications like diabetic retinopathy, diabetic neuropathy, and diabetic nephropathy. And because glucose cannot enter the cell, we need to form ATP. For that, lipolysis takes place, and increased lipolysis cause increased formation of ketone bodies and ketoacidosis. This leads to dehydration, and dehydration of the brain cells ultimately leads to coma, and that leads to death. It can be treated by insulin therapy specifically for type 1 diabetes mellitus. And for type 2 diabetes mellitus, we use hypoglycemic drugs like sulfonylurea derivatives that closes the ATP sensitive potassium channels that we have shown here. And other drugs like thiazolidinediones drugs. Thiazolidinediones drugs that decrease the insulin receptor resistance and increases resistance. Thank you.
Questions are being directed over to the audience, the faculty. Yes, ma'am. Shilpa ma'am.
Why we always say that exercise is important in a patient of diabetes? What is the role? What is the role?
None, because type 2 diabetes is mainly manifested because of the obesity. So regular exercise decreases the obesity. So capital distance.
And basically, body works on emergency and need. If there is high emergency situation where the body needs to burn down more amount of glucose or fatty acids, as glucose. Ma'am, to increase the body metabolism because the metabolism slows down during diabetes. That's why.
I mean, it will increase the glucose entry in the cell, thus the more ATP will be created, and thus insulin, more insulin will be secreted. Independent. Insulin.
Thank you.
Wait.
What is dawn phenomenon? DAWN.
No issues. It's okay. You have to learn. Okay? Good.
Thank you to the call, Bernard. So the next thing which is coming up, without the discovery of this important blood groups, as we all know, routine blood transfusion would not have been possible. So the group which is coming up on stage, Dr. Karl Landsteiner, they will be presenting the topic of urine formation of micturition. Round of applause for them.
Good afternoon, everyone. Honorable Chief Guest, judges, respected teachers, and my dear friends. Today, myself, Mohammad Ali Afal, and our group, Dr. Karl Landsteiner, are having a privilege of presenting a remarkable working model that demonstrates the process of urine formation and micturition reflex. As every one of you know, that these are very essential physiological processes which are required for the removal of the toxic substance from our body and also maintenance of homeostasis of the body. First of all, let me give you a brief introduction of our project. As you can see over here, we have magnified a microscopic structure of a single nephron which is present inside the kidney. Here you can see the Bowman's capsule, afferent arteriole, which form the glomerulus, efferent arteriole, which forms the many branches around the tubules of this nephron, and it also forms a loop around the Henle's loop, which is known as the vasa recta. It's very important for the concentration of the urine through countercurrent mechanism. Here you can see the PCT, descending and ascending lip of Henle, DCT, and we have shown here the kidney to demonstrate that DCT, it opens into the collecting duct, and after that ureter, it continues outside the kidney in the urinary bladder. Here you can see the urinary bladder and the muscular layer, which is composed of detrusor muscle, and it is under the control of the central nervous system. Here you can see the transverse section of cerebrum, pons, spinal cord, and here this is the external urethral sphincter and internal urethral sphincter. Moving beyond the static representation, our model has also been designed comprehensively to show the physical mechanism, like how glomerular filtration takes place, how urine formation takes place, how micturition reflex occur over here, and how finally micturition, that is the voiding of the urine, takes place. So first of all, I would like to invite my friend Lavya for detailed explanation of urine formation and to showcase the physical mechanism of the urine formation.
Good afternoon, everyone. I will be explaining the
of urine. The first step in the urine formation is the glomerular filtration, which is the most important step. This filtration occurs due to the pressure differentiation. That is why it is called the ultrafiltration. It occurs through the filtration membrane, and there is a pressure gradient, that is the 10 mm of Hg. It is the effective pressure. In the PCT, the filtrate will move on, and the second most important step for the urine formation is the tubular reabsorption. In PCT, there are two types in which the reabsorption occurs. In the early PCT, sodium glucose link transport channels are present that leads to the reabsorption of sodium along with glucose, and there are also some channels that helps in the reabsorption of sodium along with amino acids. In the late PCT, the sodium hydrogen exchanger is present that is responsible for the sodium absorption. PCT is responsible for the 60 to 65% of the water and the electrolyte reabsorption. In the descending limb of loop of Henle is permeable to water and impermeable to the solutes. And the water reabsorption occurs in this limb, descending limb. In the ascending limb, there are the sodium chloride and the potassium channels that are responsible for the reabsorption of these ions. In the early PCT, the reabsorption occurs through the sodium chloride channels, and in the late PCT and the collecting tubules, the reabsorption occurs due to the sodium potassium pump, and that's how the reabsorption and the glomerular filtration occurs. Now I will be demonstrating how the urine formation occurs. So this is how the glomerular filtration occurs, and the urine is filling in the bladder. Now I will call the Khushi for the further explanation.
To conserve water in our body, urine is being concentrated by the kidneys. So there are two requirements. Firstly, hyperosmolarity of renal medulla. Here, by the shades of yellow, different shades of yellow, we have demonstrated that when we go deep into the medulla, concentration of solutes increases in it. So, firstly, counter current multiplier, that is loop of Henle, generates hyperosmolarity of renal medulla due to the presence of sodium potassium ATPase pump on basolateral membrane and sodium potassium 2 chloride channels on the luminal membrane. Concentration is being created. We can see that here, as we go progressively deep into the medulla, concentration increases from 300 to 1200 milliosmol per liter. The reason behind this is the rate of blood flow in it. As in the deep medulla, rate of blood flow is very slow. It has a very less capacity to wash away the solutes. Second is the vasa recta, which acts as counter current exchanger, which exchanges urea and NaCl by both in ascending and descending limbs. Urea recycling also helps to maintain hyperosmolarity of renal medulla. Second is the role of ADH. ADH increases aquaporins into the collecting tubule, and it increases the water absorption, and hence urine is being concentrated. Now Mohit will explain the maturation reflex.
Okay, so after being the urinary bladder filled with the urine up to a threshold level, which is around 120, which is in the range of 120 to 400 ml, the urinary bladder has got receptors, stress receptors in its detrusor wall, which keeps on being stimulated by the stretching, and they send signals to the spinal segments of S2 to S4, which then ascend to the higher centers. Now, at higher centers here in cerebrum, they are being processed and analyzed until a socially acceptable condition is present around the person to void out the urine. And once the social condition is present around that person, then the cerebrum then sends motor signals towards the spinal segment again, S2 to S4, and these signals then act on the detrusor muscles to contract them, and then causes the relaxation of the sphincters of the internal urethral sphincter as well as the external urethral sphincter. And once it is contracted, then this urine which was filled in the urinary bladder is voided out. And this is how micturition reflex occurs. Thank you.
Now, myself, Aditya Kendre, on behalf of my team, extend our sincere thanks to you for giving your valuable time. Now, we are eagerly waiting for your opinion and thoughts regarding this model.
Yes, Dr. Roshan, the question.
Yeah.
Carl.
Now, what is angiotensin and how does it affect the blood pressure?
Angiotensin is a powerful vasoconstrictor which is being produced, which occurs in various forms. Angiotensin 1, angiotensin 2. The inactive form is the angiotensinogen, which is converted into angiotensin 1, and this angiotensin 1 is converted into angiotensin 2 by the angiotensin converting enzyme, which is produced by the lungs. Now, this angiotensin 2 is a powerful vasoconstrictor, and this occurs at the arteries which are being entered into the kidney, and it causes the constriction of the it increases the resistance and thus causes the decreased flow of the blood and causes increase in blood pressure.
We have a question.
What is GFR and how do you calculate it?
So GFR stands for the glomerular filtration rate, which is calculated using a substance which is completely filtered out from the urine at once, and which is neither excreted nor reabsorbed in the whole tubule, and excreted out completely through the urine. Now, what we do is we induce a certain amount of that material. Basically, we use inulin, and that inulin is being first filtered out through the urine, and then we calculate the concentration of inulin in the urine, then multiplied by the volume rate formation of the urine divided by the concentration, the normal concentration of the inulin in the blood plasma, and that is how we calculate the GFR.
We have a question by the batch itself. We have Prashant.
How the micturition regulated during the sleep?
So as Prashant has said, how is micturition regulated during sleep? Any questions by the group?
Actually, what cerebrum does is it inhibits the pudendal nerve. This pudendal nerve is inhibitory to the this external urethral sphincter, which causes its constant contraction. Now, what cerebrum does is sends descending signals to this pudendal nerve, inhibit this pudendal nerve, and this inhibition of pudendal nerve causes the release of the inhibition over the external urethral sphincter. And when we are awake and conscious, when we are not sleeping, then we can micturate it out. This is all.
Thank you. Thank you to Carl and to the group for a great presentation and an even better working model. Round of applause, everyone. Now we come to the second half of the groups which are left. The next physiologist, I can have this answer from the group itself, who made an important discovery in conditioning with the help of dogs. Can anyone tell me the name of the physiologist? Yes. So Dr. Ivan Pavlov, the group, representing the topic, which is the blood circulation. A round of applause for this group, please. Thank you.
So, good afternoon, everyone. Today, this is group number 6 representing Dr. Ivan Pavlov, and we are representing the model of the fetal circulation and the adult circulation. So, basically, the fetal circulation is distinctly different from the adult circulation. In many ways, the fetal circulation allows the fetus to get the oxygenated blood and the nutrients from the mother, maternal blood, and to remove the deoxygenated blood and the waste products. And the fetal circulation is as follows. Firstly, we are starting with the placenta. The oxygenated blood from the placenta moves to the fetus with the help of the umbilical vein. Then the oxygenated blood bypasses the liver because from here the umbilical vein directly drains into the ductus venosus. Then it continues as the inferior vena cava, which then opens into the right atrium. And the liver also drains its blood into the inferior vena cava. Thereby, the mixing of the blood occurs in the inferior vena cava, and the right atrium also receives the deoxygenated blood from the superior vena cava. So overall, there is the mixing of the blood, and the mixed blood that is then present in the right atrium and the right ventricles. Now, we saw that the first bypassing occurs in the liver, then the second bypassing occurs at the position of the heart at two places. One is the foramen ovale and one is the ductus arteriosus. Because the fetal lungs are still not functional and thereby the blood cannot move to the lungs. So it has to directly move to the fetal body. So from the foramen ovale, which is a direct communication between the right atrium and the left atrium, the blood from the right atrium will move towards the left atrium, and the ductus arteriosus, which is a communication between the pulmonary arteries and the arch of aorta. So the blood, the mixed blood, directly drains into the arch of aorta and then it moves into the descending aorta. Then the descending aorta further divides into its common iliac arteries. Then the internal iliac arteries gives the branch umbilical arteries, and the umbilical arteries carries the deoxygenated blood back to the placenta where it gets oxygenated, and the same cycle with the repeats again. So this is how the fetal circulation occurs.
Now we can also see another phenomenon happening here, that is the double bore effect that happens at the level of placenta because of the diffusion of CO2 down its concentration gradient from the fetal blood to the maternal blood. Now this decreases the pH on the maternal side, also increasing the pH on the fetal side. So this will increase the affinity of the fetal blood towards O2, thereby simultaneously decreasing the affinity of the maternal blood towards oxygen. Hence, there is a double effect working here, facilitating the diffusion of oxygen out from the maternal blood into the fetal circulation. And also we have towards the end of the gestation, the closure of these connections. First is the closure of the foramen ovale, which converts into fossa ovalis, thereby closing the connection between the right and the left atrium. Also is the closure between the pulmonary trunk and the arch of aorta from the ductus arteriosus towards the ligamentum arteriosum, thereby stimulating the pulmonary circulation in action.
Now I'll be explaining the other blood circulation. So starting from the right ventricle, the deoxygenated blood from the right ventricle via the pulmonary artery will move towards the lungs where the CO2 and oxygen is exchanged. Once this blood is now oxygenated, now via the pulmonary vein, this will reach to the left atrium. Then from the left atrium, then it will move into the left ventricle. Then from the left ventricle via the aorta, it will be supplied, it will enter the systemic circulation. Once it enters the systemic circulation, here we represent the liver as the systemic circulation. Now there is exchange of metabolites, oxygen, carbon dioxide is exchanged. Now after this, it enters the hepatic veins, then into the inferior vena cava, and finally it enters again into the right atrium, and this cycle continues. Now Shubham will be explaining about the cardiac cycle.
तो बेसिकली कार्डियक साइकिल एक साइक्लिक इवेंट है जिसमें कि हार्ट कॉन्ट्रैक्ट और रिलैक्स करता है. कॉन्ट्रैक्शन के टाइम पे ब्लड जो है हार्ट से इजेक्ट होगा और रिलैक्सेशन के टाइम पे ब्लड जो है वो हार्ट में इंटर करेगा. ईच कार्डियक साइकिल कंसिस्ट ऑफ 0.8 सेकेंड और एक कार्डियक साइकिल एक हार्ट बीट को रिप्रेजेंट करता है. कार्डियक साइकिल कंसिस्ट होता है 4 फेज के, आर्टेरियल सिस्टोल, आर्टेरियल डायस्टोल, वेंट्रिकुलर सिस्टोल और वेंट्रिकुलर डायस्टोल. आर्टेरियल सिस्टोल का ड्यूरेशन 0.1 सेकंड होता है, आर्टेरियल डायस्टोल का ड्यूरेशन 0.7 सेकंड होता है, वेंट्रिकुलर सिस्टोल का ड्यूरेशन 0.3 सेकंड और वेंट्रिकुलर डायस्टोल का ड्यूरेशन 0.5 सेकंड होता है. इनिशियल कंडीशन में क्या होता है, चारों चेंबर हार्ट के रिलैक्स होते हैं और बाइकस्पिड और ट्राइकस्पिड वाल्व ओपन होता है और सेमिलुनर वाल्व क्लोज होता है. इस कंडीशन में जो डीऑक्सीजनेटेड ब्लड है वो सुपीरियर वेना केवा और इंफीरियर वेना केवा से राइट एट्रियम में इंटर करेगा और राइट एट्रियम से ग्रेविटी की वजह से राइट वेंट्रिकल में इंटर करेगा और ऑक्सीजनेटेड ब्लड लेफ्ट पल्मोनरी वेन की मदद से लेफ्ट एट्रियम में इंटर करेगा और लेफ्ट एट्रियम से वो लेफ्ट वेंट्रिकल में इंटर करेगा. इस कंडीशन में ऐसे नोड एक्शन पोटेंशियल जनरेट करेगा जिसकी वजह से दोनों आर्टरिया कॉन्ट्रैक्ट करेंगे और ब्लड जो है वो आर्टरिया से वेंट्रिकल में जो फ्लो है वो 30% बढ़ जाएगा. इस कंडीशन इसके बाद वेंट्रिकल कॉन्ट्रैक्ट करेगा और फिर बाइकस्पिड और ट्राइकस्पिड वॉल्व क्लोज हो जाएंगे और सेमिलुनर वॉल्व ओपन हो जाएगा, जिसकी वजह से जो ब्लड है राइट वेंट्रिकल में वह इंटर करेगा लंग में थ्रू द पल्मोनरी आर्टरी, और जो ब्लड लेफ्ट वेंट्रिकल में वह इंटर करेगा आउटा में थ्रू बॉडी में थ्रू द थ्रू आउटा, और इसके बाद वेंट्रिकल रिलैक्स करेगा और फिर बाइकस्पिड और ट्राइकस्पिड वॉल्व ओपन हो जाएंगे और सेमिलुनर वॉल्व क्लोज हो जाएगा और ये साइकिल फिर कंटिन्यू होते रहेगा. Thank you.
Thank you to the Ivan Pavlov team. Any questions directed to the audience, the teachers? We have Dr. Robinson.
When does this ductus arteriosus close and when does foramen ovale close? Does it close or it remains straightened? Yes.
So the closure occurs normally during the first breath and the subsequent breaths. What happens is as there is the lungs may basically expand during the end of the pregnancy. So the alveoli become clear of the fluid that they have, and that decreases the pulmonary resistance. Due to the decrease in the pulmonary resistance, there will be increased blood flow from the right atrium towards through the pulmonary circulation into the lung bed. Now from there will be more venous return from the lungs towards the left atrium, and that will increase the pressure of the left atrium, thereby decreasing the pressure towards the right atrium. Now earlier what was there, the right atrium had the right side had the greater pressure than the left side, thus maintaining the patency of the foramen. Now what happens is, due to the decreased pulmonary resistance in the lungs and also the increased workload on the left atrium, there is increased pressure on the left atrium and the decreased pressure on the right atrium, thereby facilitating the closure of the foramen ovale, which happens with the help of the septum secundum descending down the septum line.
Can you just enumerate some cyanotic heart disease?
There are two kinds of diseases, cyanotic and acyanotic. Cyanotic usually occurs from the right to left septal defects, and tetralogy of Fallot is a great example of this cyanotic disease, which is a rare condition in which four things happen simultaneously. One is the ventricular septal defect, second is the pulmonary stenosis, third is the right ventricular hypertrophy, and fourth is the displacement of the aorta from its normal position towards the anterior side of the ventricular septal defect.
We have a question by Dr. Ragini ma'am as well.
Okay, you told about the change in the circulation. One thing you missed, is there any change in the blood also of both the sides, like in the fetus and in the adult? Is there any? Yes.
Ma'am, in the fetal circulation, we saw that there was the mixing of the blood, and therefore in the heart, there was the mixed blood throughout. But in the adult circulation, since there is no bypassing, so the right atrium carries the deoxygenated blood purely, and the left side carries the oxygenated.
What I am asking, is there anything between fetal blood which is helping in catching the oxygen from maternity?
Yes, fetal hemoglobin has also chemically different globin chains. It has two alpha and two delta chains, which has no affinity with 2,3-DPG, which decreases the affinity for O2. So there is no decrease in affinity of O2 in the case of fetal blood. And in case of adult hemoglobin, what we have is two alpha and two beta chains normally. Now those.
Thank you, team. Round of applause for them. We will now hold a recess for 5 minutes, after which we will continue with the rest of the groups. Dr. Wilhelm Maximilian, who's also the father of experimental psychology, and they will be presenting on the topic of chemical regulation of respiration. So this team can present and assemble their project over here till the recess is done. Thank you.
Great work, Dr. Imam.
So are you ready, team? Okay, you can start.
Keep quiet.
Good afternoon, honorable judges and respected professors. We are the group William Maximilian, and we are going to present chemical regulation of respiration. So, our respiratory system is mainly regulated chemically and neurally. In chemical regulation of respiration, there are two types of receptors. A type of receptor is present peripherally, known as peripheral receptors. Peripheral receptors mainly consist of glomus cells. These glomus cells are present in aortic bodies and carotid bodies. Then we have central chemoreceptors. Central chemoreceptors are present in the brainstem. In the brainstem, we have this area pons. The pons has pneumotaxic center and the aponeurystic center. Then we have medulla. In the medulla, we have dorsal respiratory group and the ventral respiratory group. In the ventral respiratory group, we have nucleus ambiguous and nucleus retroambiguous. Nucleus retroambiguous further has caudal part and the rostral part. This whole system is present in CSF, and this is separated by a blood-brain barrier from the blood. This is TS of brainstem and this is TS of spinal cord. Now the mechanism of peripheral chemoreceptors will be explained.
Hello everyone. So peripheral chemoreceptors, basically they are present at two locations. One is at the arch of aorta, that are the aortic bodies, and one is at the bifurcation of the common carotid artery, that are the aortic bodies. These carotid and aortic bodies, they contain chemoreceptors in the form of the glomus cells. They also have type 2 cells, which are known as the sustentacular cells or the supporting cells. Now, these peripheral chemoreceptors they are more sensitive towards the decrease in the oxygen concentration, and they will sense the decrease in oxygen concentration only when PO2 falls below 16 mm of mercury. This decrease in oxygen is sensed by the glomus cells via three mechanisms. First is the heme-containing protein. Oxygen will dissociate from the heme-containing protein, and this protein are present near to the voltage-gated potassium channels. Second mechanism is increase in the CAMP levels. That will also is a mechanism to sense the decrease in oxygen. And the third one is the increase in the GSH by reduced to the oxidized glutathione ratio, which will be sensed by the mitochondria of the glomus cells. All this will cause the glomus cells to detect the decrease in the oxygen. This decrease in oxygen will inhibit the potassium voltage-gated channels, and therefore the efflux of the potassium from the cell to the ECF will decrease. But still, the sodium and potassium leaky channels are functioning, due to which the sodium influx will occur, and that will cause the depolarization of the cell. Once the cell is depolarized, it will cause the opening of the voltage-gated calcium channels that will lead to the influx of the calcium ions. The increase in the calcium concentration in the cell causes the vesicles containing the neurotransmitters to release the neurotransmitters. Basically, there are three types of neurotransmitters that are possible: dopamine, acetylcholine, and the ATP. These neurotransmitters will bind to the receptors of the postsynaptic neuron, and that will carry the signal to the DRG and VRG. The point to be noted is aortic bodies, the signal from aortic bodies will be carried by the vagus nerve, and through the carotid bodies, it will be carried through the glossopharyngeal nerve. Now, the increase in the CO2 concentration can also be sensed, but the glomus cell will be less sensitive towards the increase in the CO2 concentration. CO2 will enter into the cell, it will bind with water to form bicarbonic acid, and that will dissociate to form HCO3 minus ion and the H plus ions. The increase in the H plus concentration in the cell will inhibit the potassium channels, and the same mechanism repeats. Another one is decrease in the pH. Decrease in pH causes the increase in H plus concentration in the ECF. Once the H plus ions are increased in ECF, it will stop the efflux of the hydrogen ions from the cell, so it will inhibit the sodium-hydrogen exchange bonds, and it will open the hydrogen channels, due to which the hydrogen will go into the cell, and therefore the concentration of H plus ions into the cell increases. That will also cause inhibition of the voltage-gated potassium channels, and the same mechanism repeats. Now we'll see the central chemoreceptors.
The central chemoreceptors are mainly present in the ventrolateral part of the medulla. Recent studies have shown that they are also present in the nucleus tractus solitarius,
the locus coeruleus, and the hypothalamus. The main function of the central chemoreceptors is to detect the H plus ion concentration of the CSF. Hence, the chemoreceptors detect the pH of the CSF and the PCO2 of the arterial blood. However, they are less sensitive or cannot detect the H plus ion concentration and the bicarbonate ion concentration of the blood. This is due to the presence of a blood-brain barrier which does not allow the H plus ions and the bicarbonate ions to cross to the CSF. However, CO2 can cross the blood-brain barrier to go to the CSF. Now, when the CO2 concentration of the arterial blood increases, the excess of the CO2 crosses the blood-brain barrier and goes to the CSF. There it associates with a water molecule to form carbonic acid, which then dissociates to form H plus ions and bicarbonate ions. These H plus ions stimulate the chemosensitive areas, which would stimulate the DRG and also stimulate the pneumotaxic center. The pneumotaxic center would stimulate the DRG would stimulate the VRG, and these all would lead to increase in the rate of impulses being conducted through the phrenic nerve and the alpha motor neurons to the diaphragm and the external intercostal muscles, and hence consequently the rate and depth of inspiration would increase. Thank you.
Can you just enumerate some respiratory disorders, like what is COPD? COPD stands for chronic obstructive pulmonary disease. In this, the surface area of the lungs decreases. Unlike the surface area of the diffusion of the gases decreases, and because of this, a respiratory acidosis can occur. So this is the one.
What happens in mountain sickness and how it can be prevented?
Sir, at higher altitudes, the PO2 of the atmospheric air decreases, due to which the PO2 decreases. So, at the level of the lungs, the dissociation PO2 has decreased. So, HBO2 would dissociate, and PCO2 in the blood would increase. And hence the respiratory rate would increase in order to expel the CO2. At high altitude, for some time there would be motion sickness, but mountain sickness, but then the RBCs would increase in order to accommodate to the low PO2 of the air.
Firstly, we can acclimatize the patient to high altitude by increasing the frequency of trips to high altitudes before he goes to a they can ask the patient to gradually go to the high altitude.
Ma'am, I have seen. Victim se baat
There will be the blood clot formation in the respiratory tract, due to which there will be obstruction.
What will happen? Hampered? Hampered क्या होगा?
Oxygen delivery and ventilation will be affected.
What is the uniqueness of therapy story?
There the blood flow is very much higher, due to which a slight decrease in the oxygen level can also be detected, and therefore the respiration can be regulated. Arterial oxygen. Dissolved oxygen.
The oxygen carrying capacity of the blood will decrease in anemia. So because of that, the hypoxia condition will take place, and due to the hypoxia, this mechanism, the glomerulus cell will be stopped. More stimulation.
Sir, because it detects the level of the partial pressure of oxygen. Since it is binded with the hemoglobin, it does not affect the partial pressure of oxygen.
Well, a round of applause to this team to show great and persistence to all the questions which were directed to them. Thank you. And we shall have our next group. So over here, as everyone must have learned, there was this important equation which everybody remembers, Nernst equation. So with that, we'll be calling on stage the group of Dr. Walter H. Nernst, who will be presenting the topic on descending tracts over here. A round of applause on them.
गानी फिर मेहमान
A very good afternoon to one and all, respected jury members, respected professors, and all my dear friends. Today, we are here to present a project on descending tracts with the help of a 3D model, as you can see, and with the help of a place kit. So this place kit over here describes, we are showing a patient. His name is Mr. Kapoor. He's 32-year-old male with a history of hypertension, and he has been rushed to the hospital by his family because he was found fallen while taking a bath in his bathroom. He has a history of hypertension with the BP being 220 to 120 millimeters of Hg. And in the scene here, we're going to be seeing two doctors performing various tests on him and accordingly explaining simultaneously the model. I'll hand it over to Archie.
Good afternoon, everyone. We will be doing the phase kit and explaining the physiology and the related pathology at the same time. I will be explaining the physiology of the descending tracts. We have made a model which depicts the descending tract. We have depicted the pyramidal tracts, which are divided into corticospinal tracts as well as corticobulbar tracts. Here we have depicted corticospinal tracts, which start from the cerebral cortex, from the motor, 30% from the motor area, 30% from the premotor cortex, and 40% from the somatosensory area. So they descend from the level of the cerebral cortex down to the level between in the internal capsule between the lenticular nucleus and the thalamus, then down to the level of midbrain, the pons, the medulla. At the lower level of medulla, they bifurcate. 80 to 85% of the fibers cross to the contralateral side, which are then termed as lateral corticospinal tract, whereas the 10 to 15% do not cross and are termed as anterior corticospinal tracts. Their functions being the lateral corticospinal tract help in motor movements throughout the body and fine and creative movements of the hand, whereas the anterior corticospinal tracts help in gross movements and posture related movements. The corticospinal tracts here have been depicted by the simple wires,
whereas the lateral spinal corticospinal tracts have been depicted by the ones which is lighted up, and they descend down up till the termination of the spinal tract, whereas the anterior corticospinal tract terminates at a certain level in the spinal cord. Their function also, we will be taking up upper motor neuron lesions and lower motor neuron lesions. So I will also be explaining the upper motor neurons, which are the first order neurons which descend from the cerebral cortex itself, whereas the lower motor neurons are the one which directly innervate the viscera and the muscles and are responsible for the various movements and the autonomic functions as well. Now I will be handing over the mic to Diksha, as well as we will be doing the place kit, which will depict the various tests on the patient. Thank you.
Now, first, we will perform the sensory examination for a patient, which are fine touch, acute touch, vibration, and pain.
Put the mic in front of it.
जब फील होना बंद हो जाए तो बताएं. Then we will perform pain sensation. Pain feel हो रहा? Yes. इसमें okay. दोनों में same. Then we perform fine touch. Feel हो रहा? Feel हो रहा? दोनों में same. Then we perform throat touch. फील हो रहा है इस साइड.
Sensory examination in both the sides are showing the normal response, which shows that the acidic tracts are intact on both the sides. Now we'll be performing the motor reflex examination. First examination being the knee jerk reflex, which is a monosomatic. On the left side, the knee jerk reflex was normal, but on the right side, the knee jerk reflex wasn't elicited because which shows that the spinal cord may be in the state of shock. Now we'll be doing the reverse reflex. To the rescue. The rescue response on the left side was negative, which showed the normal flexion of the toes. But on the right side, there was no response, again because the spinal cord may be in the state of shock. But if there is an upper motor neuron lesion, there will be a positive rescue sign, which is the fanning out of toes. I'll be handing over the mic.
So according to the findings in the experiments, the diagnosis suggests that it is not a cerebral cortical injury, otherwise it would have resulted in the monoplegia. It is also not an upper spinal injury, otherwise it would have resulted in quadriplegia along with respiratory failure as well. It is not even a lumbar injury or a lower spinal injury, otherwise it would have resulted in paraplegia for the lower tooth limbs. It is not an injury of pons, that is pontine injury. As in pons, the fibers are dispersed and it would have haven't resulted in complete paralysis. It would have resulted in some partial motor loss. It is not even a medullary injury, otherwise the fibers which do not cross would have resulted in some kind of paralysis on the same side as well. So most probable diagnosis suggests that it is it was caused due to an hemorrhage in the internal capsule. The most probable cause of hemorrhage is the fall which the patient suffered as he missed his medication.
I'd like to just conclude here very quickly. So I'd like to point it out here that the first 16 years after a stroke for a patient are called the golden period of stroke, because if the patient is rushed to the hospital in this time, then it will be easier to manage the case, and permanent loss in this case in general is not observed. Also, in these cases, immediately the patient is sent to have an MRI to find whether it's an ischemia or it's a hemorrhage, which was also done in this case. And it was very good on the part of the family to bring the patient within the first 60 minutes. I thank you all to be here with us.
Thank you, team. Any questions directed?
Can you enumerate some lower motor neuron lesions?
So whenever any neuron which is directly innervating the any of the viscera or any of the limb is directly injured is the lower motor neuron lesion, which might be the case whenever there is a knife injury, a stab or anything which directly affects the nerve which are supplying to the viscera or the limb.
We have Dr. Shilpa, who's going to have a question.
Do you know any disorder with hyperkinesia, rigidity, and tremor, a triad of this very common thing? Which condition have all these people?
Great question by Shilpa ma'am. Does the team have an answer?
Ma'am, did you ask about the basal ganglia or basal? Okay. Parkinson's?
Yes, that's great. Thank you, group. You can.
There are two parts, medial and lateral. This is the medial motor system. What is the function of medial motor system and lateral motor system? Just like in sensory, there are two parts, dorsal column medial hemisphere system and anterolateral system. In motor also there are two parts, medial and lateral. But majorly it is a lateral system or motor. Right.
Thank you to the water external team. Thank you. So the next group, as we are falling short of time, we have only two groups left.
I'm not sure about this. I'm very sorry.
Thank you. So the next group, the scientist shares the name to all the books which you all have been reading. One of which is Guyton and Hall, and the other is Ganong. Specifically to the syndrome by this scientist is the lone Ganong-Levine syndrome, which is an electric abnormality in the heart. So the group which is up next is Dr. William Francis group, which will be presenting the topic of the sliding filament theory. So a round of applause for the team. All right, Aish, ready when you. Okay, so a very good afternoon to all the judges, all the respected professors, all the tutors, and all my dear friends who have come here to attend our representation. So today I'm holding this mic. We are all able to walk. The question is, how is it possible? So as you can see, we have made a chart representing the sliding filament theory. So all these movements are possible because of the contraction of the muscles. And this muscle contraction occurs in the body by the help of sliding filament theory, which was demonstrated by Henson and Huxley in the year 1954. So I'll begin explaining our model. So over here in the green color, we have tried to depict sarcoplasmic reticulum, and the terminal ends are called as the cisternae. And over here we have represented T tubules. So basically, whenever an action potential comes, the function of the T tubules is to transmit that action potential into the sarcoplasm. So going into the details of the model, over here we have represented a pink colored M line, in pink colored Z line, and in the middle we have the yellow colored M line. So basically, as we all know, that the distance between two Z lines is what we call as the sarcomere, and it is the functional unit of contraction. The Z lines have attachments to the thin filaments that are known as the actin filaments, whereas the middle M line, which is present in the Henson zone, has attachments of the thick filaments that is known as the myosin filaments. So myosin filaments, as you can see, we have these tubular projections. These are called as myosin heads, and these are also known as the cross bridges. These have two sides, one for the binding of ATP and another for the binding of actins. And in detail, I'm sorry, I don't think this would be visible to you, but over here in the actin filaments, we have spiral threads that we're trying to depict the tropomyosin protein. So basically, the tropomyosin protein covers the binding site for myosin, which is present on the actin. Over here, we have troponin molecules, troponin proteins, which is again have three components: TPI, TPT, TPC. The TPT is responsible for the binding of troponin to tropomyosin. The TPC is responsible for binding of troponin to calcium, and TPI basically inhibits the interaction of actin with myosin. So, and one more thing, this yellow strips you can see over here, this represents titin protein, also known as connectin protein, and these are the largest protein present in the body, and it is also responsible as a spring. So basically, after contraction, what we need to do is the myosin proteins need to be on their original position. So these are responsible for maintaining the integrity of the sarcomere. So that is all. One more thing I would like to state that the diameter of a myosin is around 15 nanometer, while that of an actin is about 7 nanometer. So the ratio between them is 2:1, which we've tried to depict over here. Rest for explanation of the mechanism of contraction, I'd like to hand over the mic to Ashma.
So the whole mechanism of contraction basically starts through the calcium ion. So as soon as calcium ion is released from the sarcoplasmic reticulum and it enters the cytoplasm, it binds to the troponin C component present on the actin. As soon as it binds, it causes conformational changes which pulls the tropomyosin from the actin filaments, and it further exposes the myosin binding sites present on actin. At the same time, on the myosin, ATPase activity is going on, through which ATP dissociates from the myosin head and it exposes the actin binding sites present on the myosin. So as soon as both of these sites are exposed, the myosin binds to actin and it pulls the actin filaments inwards, which is basically what is called the sliding filament theory, as there is no actual shortening of the filament, but basically the myosin pulls the actin filaments inwards by formation of cross bridges. Thus, this model is known as the sliding filament theory, and the next cycle begins as soon as another ATP comes and it binds on the myosin head, which masks the actin binding site, and the cross bridge breaks and the muscle is able to relax. After the muscle contraction, this middle darker part that we see is the A band, which is mainly composed of the myosin and some part of the thin filament. On either side of the Z disc, we see the I band, which is only composed of the thin filament part. Within this A band, we see the two areas. The middle lighter one is the edge zone, which only has the myosin, no thin filaments. And on either side of the A, the darker part of the dark zone is the O zone, that is the overlapping zone, where the actual overlapping takes place. During the muscle contraction, the length of the A band remains the same, while that of the I band decreases, and that of the L zone also decreases, while that of the O zone increases. As the person dies, he or she is not able to form ATP. So what happens is that cross bridges binds with the binding sites, but they are unable to detach back. Moreover, the binding sites on the actin remains uncovered. For them to be covered, we require calcium to be pumped back into the sarcoplasmic reticulum, and for that also we require the ATP. So this all leads to the rigor mortis. But the rigor mortis eventually disappears because the lysosome starts eating up the various proteins in the muscle fibers. Thank you.
As we want to show the molecular level of muscle contraction, we can show that when the ATP is bind to the head of the myosin, then the actin and the myosin get detached. So that then the ATP get hydrolyzed into the ADP and inorganic phosphate. But the hydrolyzed product is not detached from the head; it is remain attached to the head. But when this leads to from the myosin head to the puff position, which is the position of the myosin head in the between of the actin and the myosin in perpendicular position. When then the myosin head will bind to the actin binding side of the for the myosin, and then the inorganic phosphate will be released from this myosin and head. This leads to form the stage of power stroke, which means the actin filament now pulled to the tail of the myosin in approximately 11 nm in length. Then after releasing the ADP, the myosin head remain bind with the actin molecule. Here the role play in the ATP. When the ATP again bind to the myosin head. Thank you everyone for listening us. Thank you for your patience.
We have a question by Dr. Roshan, sir.
What do you understand by myopathies?
The myopathy mean generally the decrease of the muscle that we are found. We have been seeing the muscular dystrophy. We can see that there is a mutation of the gene in the dystrophy that leads to the decrease in the muscle count. There are two types of muscular dystrophy. Then in the Denken muscular dystrophy, which mainly affect the all dystrophin protein are absent from the muscle, and we can the Decker muscular dystrophy, in which the partial amount of the dystrophin is present. In the Denken muscular dystrophy is mainly the X-linked related disorder, and this leads to shorter in the tyrosine protein that discovered by the eyes, and this leads to cardiac myopathy and all that.
We are being followed by a question by Dr. Shilpama.
What is the role of ryanodine receptor? What happens if there is a mutation?
So what happens? No, the receptor present in the T tubule is the dihydroiodine receptor. When the calcium is bind to this receptor will change the configuration in the ryanodine receptor. The ryanodine receptor again and which is this release the calcium from the sarcoplasmic reticulum. The ryanodine receptor has a very important role. That it acts as a calcium-induced calcium release factor. When the calcium is released from the sarcoplasmic reticulum, this calcium again binds to this receptor, and this again stimulates the release the calcium from the sarcoplasmic reticulum. So that it increases the muscle strength, and where there is a mutation in this receptor, there will be a decrease in calcium count in the muscle, and there will be muscular weakness and something.
Great answer, Vikas. Thank you. Thank you for the question. I apologize, we do not have time to entertain questions by the audience, but now we have.
What are the other names for this sliding filament theory? Other names? Other name for the sliding filament?
So for the walkthrough theory, we say walk along. Yes, sir. Walk along.
Sir Henson and Huxley. Well, 1954. All right. With this, we come to the last group, and without him, we couldn't have made possible the charting of the electrical rhythms in our heart, the EKG or the ECG. So the next group and the final group for today's working model presentation, Dr. Wilhelm Einthoven group, who will be presenting on the topic of visual pathway. A round of applause for our last name for today. Thank you.
Are you ready, team? You can start.
Good afternoon, respected professors, judges, and my fellow batchmates. So, as we all know, that eye is an important sense organ in our body, and it helps to perceive the beautiful world around us. But here is the question that how does this work? How are the signals transmitted from the retina of the eye to the visual cortex? So here is our group, and we will try to explain the visual pathway today. So first, I would like to call upon Gopal to explain our model.
Good afternoon, everyone. I am going to demonstrate how the visual pathway works. So, as we all know, the visual sensations, they arise in the rods and cones of the retina, which act as the end organs, which then convey the visual sensations to the bipolar cells, and those are then transmitted to the ganglion cells. So, from the retina, the fibers of the ganglion cells, they congregate or converge to form optic nerve, which comes out of the optic disc. Now, the optic nerve, it travels to the optic chiasma. The chiasma, a point where half the fibers from each eye, they cross over, and after the chiasma, the fibers, they travel as optic tracts to the lateral geniculate body. Now, at the chiasma, the fibers from the nasal half of the retina, they cross the midline and get interchanged. And the fibers from the temporal half of the retina, they travel in the same optic tract. So, in other words, we can say that the left optic tract, it contains fibers of the left half of the retina, which is the right visual field, and vice versa. Now, talking about the optic tract and the lateral geniculate body, from the lateral geniculate body, the crossed and the uncrossed fibers, both the fibers, they reach to the ipsilateral primary visual cortex as optical radiations. We call it as optic radiations because the fibers, they emerge out, they spread out from the lateral geniculate body. Also, these are also known as the geniculocalcarine tract, because the primary visual cortex is located on the sides of the calcarine fissures along the medial sides of the occipital lobe of the cerebrum. And talking more about the lateral geniculate body, it performs two main functions. One, which I've already mentioned, it controls it is responsible for the transmission of the visual sensations from the optic tract to the visual cortex. And this transmission, it is very, very accurate, and involves point-to-point transmission with high degree of spatial fidelity as well. Also, the second function of the lateral geniculate body is that it controls the amount of sensations which are passed to the visual cortex. So, in a way, it performs two functions. It transmits as well as controls the amount of the transmission of the visual sensations. It receives some of the gating control signals from two major areas, like one is the reticular areas of the mesencephalon and another one is the and in this way the reticular areas of the mesencephalon, they are inhibitory, and when they are stimulated they turn off the transmission through some modulations in the lateral geniculate body. Thank you, and I'll hand over the mic to Ambrish, who will explain some of the lesions of the visual pathway.
Good evening, everyone. After we saw the normal visual pathway, I would like to discuss some of the lesions occurring in this pathway, which leads to the some different kinds of blindness. And one of these lesions can be at the level of optic nerve, as all the visual fibers emerge from eye through this optic nerve. So any lesion at this level will cause the complete blindness on the lateral side on which the optic nerve is damaged. The second lesion site can be at the level of optic chiasma, where there is an crossing over of the nasal component of the hemiretina, and also we know that the nasal side of the hemiretina takes the sensation from the temporal field of vision. So there will be a bitemporal hemiapnea, that is, we can't be able to see the temporal field of vision. And the third can be at the level of optic tract, as it contains the temporal fiber of the ipsilateral side and the nasal fiber of the contralateral side. So it will lead to the right homoapnea, right homonymous hemiapnea, and the again there can be lesion at the level of geniculocalcarine tract, which leads to the right homonymous hemiapnea, but in this case the macular fiber which projects through a different tract on the cortex, and also they have a greater presentation, they are not injured, so the macular fibers are preserved in these lesions.
Thank you, team. Over to the audience. Judges, any queries?
If there is a raised intracranial pressure, how does it affect an optic nerve?
Sir, optic nerve also have the discoveries of meninges over it. So any increased amount of CSF also increases the pressure in the optic nerve, which may also push the eyes like outside exophthalmos, and also it may cause the damage to the optic nerve, leading to some blindness.
How do people, like, why there is constriction or dilatation of pupils? How it is regulated? The dilatation and the constriction of pupils.
So it is regulated through the accommodation reflex. Basically, first when the light is incident, the impulse will travel through optic nerve, then optic chiasma, then the optic tract, lateral geniculate body. Then it will reach the visual field cortex area number 17. Then it will reach the frontal eye field area number 8, which is the primary center for the accommodation reflex. Then it will travel to the Edinger vestibule nucleus of third cranial nerve, through which that will conduct the impulse to the ciliary ganglion, which will transmit impulse through the short ciliary nerve through the to the ciliary muscles and the constrictor pupillae muscle. So that will cause the constriction. It will cause stimulation of the constrictor pupillae muscle and cause the constriction of pupil.
Thank you, team. Okay, ma'am is having a question.
What is the importance of this phenomenon? You explained it very nicely. What is the importance? And second question, what is visual blindness? Color blindness. Ma'am, the importance is there is a clinical condition associated with it called Argyll-Robertson pupil, where the pupillary reflex will be intact, will be lost, where the accumulation reflex will be intact, where the pupillary reflex
Normally also why it is useful? Why this restriction is useful?
for near vision and far vision. Daylight.
What is color blindness?
Significance of color. Reason why it is important to know whether a person is colorblind or not.
So it may be useful in some of the professions like pilots and other to see the signals.
How about how it is useful in medical schools, medical profession? That is very important. How are we concerned with color blindness?
Is it a disability or not for this profession?
You can just, if anybody is colorblind, you can just take him in medical profession and go on.
How it's a doctor?
All of you have undergone an upcoming examination before joining. Why was that done? If there is color blindness for red color, it would be
Difficult for a medical student to enter the surgery profession.
Thank you, team. So that was the last and the final team, Team William is over. So now I would like to call upon Dr. Varun Malhotra, sir, to kindly take over.
Thank you very much. Thank you. This event was for the students, by the students, and of the students. As Abraham Lincoln has said, I'm not here to give a thank you note, but since it's for, by, and of the students, I would like to invite some of the students to give a feedback. So, one of the students from that group, you want me to name you, or you're going to just come down? Yeah. So please come, and we'd like to see how did you, can you please clap for the students who given their feedback? How did you like this entire experience?
Good morning, everyone. Sorry, good afternoon, everyone. And this was an enthusiastic experience, making this model and preparing for the like this models, preparing about different topics and learning new things, and like running to the BDA and everywhere for the stationaries and all. Although I was not present here, I was at my home. So with my batchmates, my teammates made this model. So on behalf of them, I'm like sharing my experience, and like it was very good experience because we learned different things, and I hope that we'll conduct it in the further years also.
How it assisted in your learning?
Ma'am, actually, some topics were there. These were the broad topics which we have learned in the first year. So we like revised it kind of, and we like the questions also just gave us a pinch of key that we were missing on that. So we had to like work on that topic. So like that. Thank you.
Want to announce the results? Okay. So just I'll share one small thing. In fact, I did meet some of the students personally in VDA. I had come there for buying these pens, and they wished me, "अरे तुम लोग यहाँ कर रहे हो?" Sir, this is Ragini ma'am's batch. Sir, हम लोग वो lung का picture लेने आए हैं. Who were those two students out there? So I met both of you, right? And some of the students, not only VDA, they went back walking all the way to the market at the back, So really hands-on experience. All of you The NMC norm says didactic lectures hone nahi chahiye, and I think this is the first kind of thing that we are trying to our directors.
Plain paper.
The idea of having these models, you must clap with Dr. Rekha's ma'am, I must say. Because of her, that we all had so much of fun. We were continuously with your coordinator for the entire thing, that burden of scheduling. I kept saying that we have models, so actually foundation was a 1 day got extended for 3 days. And all the before, but I must thank the judges also. They've been such a patient lot. Dr. Roshan Jizlani has actually had a very complicated case from pediatric surgery, and Dr. Kavya ma'am, Dr. Ashok, please clap for them also. They've actually been very patient audience. They are finalizing the result. So I must say this event is also YouTube live. So I must thank Shivam here. Please put your hands together for him. He's actually came to me and he said, "Sir, we have never done this before, but let us see if we can manage this." And Director Sir had told our Head of Department, respected Honorable Sir, that can we go Facebook Live? Our Director Ajay Singh plans very huge. He's actually awakened everybody and stretched even the students, as you can see in this event. And Sir said, probably, sir, we can try it. And I just asked Shivam and he says, "Sir, let me try it." And that is important. First, that should be the response, not that no or nahi ho payega. So, sir, are you ready with the result or right? Okay. And I would like in the meantime one more student to come and give a feedback. You would like to give a feedback, Mohit? Come. Devin, are you want to ready also? Let's see who can come here first. Okay.
Okay, so there had been 4 sleepless nights, 5 study days, which equaled so much fun, experience, knowledge, and much more. मतलब हमने बहुत सारे वाटर पंप जलाए, हमने डायरेक्ट एसी में लगा दिए थे पार्ट, फिर हमने लाइटिंग्स लगाई तो कभी उल्टे कनेक्शन लग गए तो वो पूरा फिर से निकालना पड़ा. देन समटाइम्स लीक अकर्ड तो उससे पूरा प्रोजेक्ट गीला हो गया. तो वी विल लाइक ड्राइंग इट अगेन एंड अगेन. तो बस यही था कि creating, then remodeling, then फिर से breaking, then creating, and after all the result was so relieving. Thank you.
Must tell you, the same experience which he shared, I think it was the micturition model you were saying, right? So हम लोगों का आरी काट के 100 कर रहे थे, वायर्स जाके खरीद के आए, पंच करना था. वो जो आपने स्पाइनल कॉर्ड के बोर्ड्स देखे, those are your boards of your faculty which are pasted. उसको हम लोगों ने काट के, किसी का उतारा नहीं. कहीं मिल गया था तो वो उठा लिया. So those are how the innovations happened. So please.
So on behalf of the Department of Physiology, I would like to congratulate each one of you for an excellent presentation. One of the best scientific exhibitions ever seen. Say thanks to all the mentors and the teachers who have put in efforts to make you ready for this presentation. So I think you should clap for your teachers as well. But everybody presented very well, very nicely, but we have to select one of the winners. So what we did is, we were given this chart, and the charts were based on the marks we had to distribute based on making the presentation, the description, the clarity of the subject, and innovativeness. So we were distributed marks on the basis of making, innovativeness, presentation, description, and clarity of the subjects. So the marks were distributed according to it. And so what we did is, we made the first ranker, the second ranker, and we have 2 third rankers. So it was very difficult to judge everybody, and with the consensus of all the 3 judges, we could make out the first one. I'll announce the third one first and then coming to the first one. So the third, we have tie of third rank, and the third rank goes to William Maxwell, the group of William Maxwell. Again, we have a tie on the third rank, and the third rank again goes to Baldev Singh. Come on the dais and let us have a photograph and your celebration as well. So coming on to the second rankers, the runners up. The second ranker were William Francis. You can also come on the line. Now, it's time to announce the winner of the competition. And the first prize, I think it is a unanimous decision. There was no much controversy, no much confusion. The first prize goes to Carlen Steiner.
Remember one thing, I can see some faces. All of you are winners. All of you have worked hard. So clap to all of you. कहते हैं कि कर्म करो फल की इच्छा मत करो. All of you have learned in the process, and you have made. You see the aura of this room has absolutely changed. I would also request our we are honored to have our Dean Student Welfare here. Please put your hands together for him, please. Louder claps, please. We have to be very senior.
अब तो मेंटर्स खड़े हो सकते हैं ना अपने सारे हमारे बच्चे हैं.
Can we have the faculty up also on stage, please? Can you put your hands together for the faculty? All faculty, all faculty.
बाकी सारे मॉडल्स के साथ सारे बच्चे हाँ सबको बुलाओ.
बहुत इतना क्राउडिंग हो जाएगा यहाँ पे यार. पर
इस तरह मॉडल रख के सब इधर आ जाओ. मॉडल्स ऐसे रख लो कि for yourself at that moment of time. So appreciate that effort, appreciate your teamwork, right? And you learn a lot of things. Good.